disseminated intravascular coagulation. It means widespread microthrombi formation due to hypercoagulable state in the arterial system and venous system. Due to widespread endothelial injury, this causes activation of both extrinsic-intrinsic pathway of coagulation and formation of clot and consumption of platelets. So there will be low coagulation factor in the blood as well as low platelet in the blood, and this will manifest as bleeding and multi-organ failure. Bleeding from in the skin in the form of non-palpable purpura, ecchymosis, bruising and gum bleeding, epistaxis, bleeding from the venipuncture site, and patient even may have overt DIC but may present without bleeding. So the patient have other feature of multi-organ failure. Multi-organ failure in CVS, heart rate will be more than 100 beat per minute. Delayed capillary refill, that means you will press in the nail bed for 5 seconds and it will be pale and you will release this. If it fulfills within 2 seconds, it is normal, but in case of poor peripheral perfusion, it will be more than 2 seconds. Number 1. Number 2, there will be cold periphery and patient will be confused, and oliguria. Oliguria means urine output will be less than 0.5 ml per kg body weight per hour. So the patient may respond with IV normal saline infusion. If does not respond with this, patient may respond vasopressor, that is dobutamine, noradrenaline and dopamine. And now you look for renal failure. Renal failure is indicated by oliguria or anuria, but oliguria means urine output less than 0.5 ml per kg body weight per hour. Fractional excretion of sodium, it is very much important. If it is less than 1%, it is pre-renal azotemia. That means kidney is still preserving sodium due to low perfusion. Fractional excretion more than 1%, that means kidney cannot reabsorb sodium, and it is due to established acute tubular necrosis. In this case, urine will show muddy granular cast amorphous sediment and mild proteinuria. And it will also indicate the causes of acute renal failure, such as White's WBC cast and eosinophil in acute interstitial nephritis, such as allergic interstitial nephritis, such as due to drug, and RBC cast hematuria due to glomerulonephritis, and white cell and WBC cast bacteriuria in case of pyelonephritis. And there will be also failure of hematological system, that is platelet count will be less than 80,000, and also platelet count may be less than 50% of the previous baseline report, and there will be DIC. You see it is a part of multi-organ failure, and pH will be less than 7.3, that means acidosis, and lactate will be more than 2.4 millimole per liter. This indicates widespread poor perfusion that leads to lactic acidosis, that is anaerobic glycolysis. So for renal support, you see renal function is if the renal function is diminished, your treatment will be: number 1, correction of normal blood pressure by normal saline or vasopressor. Number 2, your response will be dialysis, no diuretics. And number 3, your response will be management of acid-base imbalance by intravenous sodium bicarbonate injection. Your response will be correction of hyperkalemia. Due to it is dangerous, it may lead to death. And number 3 is respiratory. Respiratory rate may be more than 22 breaths per minute, and it may manifest with cyanosis due to oxygen poor oxygenation. You will give oxygen to maintain saturation more than 95%. If high flow oxygen fails to maintain the oxygen saturation, you must go for intubation and ventilation. Carbon dioxide retention also occurs in case of type 2 respiratory failure, that is acute respiratory distress syndrome or ARDS develops. Carbon dioxide retention leads to warm periphery, confusion, drowsiness, coma, flapping tremor. These are the feature, and carbon dioxide retention is an absolute indication of intubation ventilation, because there is no way to remove carbon dioxide from the body. And there is sign of liver failure due to poor perfusion in the liver and acid base imbalance, and it will manifest by jaundice, because in DIC there is in DIC you will find intravascular hemolysis and jaundice and hyperglycemia. This is due to poor insulin activity in the blood and requirement of steroid. That means to maintain blood pressure and to limit the inflammatory response, you may need intravenous steroid. So these all are the feature of multi-organ failure, and these all may be usually associated with DIC. So what are the causes of DIC and multi-organ failure? Look, infection and sepsis. It is the commonest worldwide. You will remember the one of the cause of DIC or multi-organ failure is infection or sepsis. Other is trauma, major trauma, multiple trauma, pancreatitis and burn. These things looks like traumatic. Trauma, pancreatitis, burn. Preeclampsia, eclampsia, severe liver failure, malignancy, and other ABO incompatibility, snakebite, and recreational drug. There is a criteria, this is International Society of Thrombosis and Hemostasis criteria. If you suspect the patient having DIC, but still not 100% confirm that patient either have or doesn't have DIC, you will do this investigation, and if the point is more than 5, compatible with over DIC. If point is less than 5, you repeat 1 to 2 days. What investigation you should do in case of DIC is in CBC. You will see decreased hemoglobin due to DIC, as DIC leads to thrombotic microangiopathic intravascular hemolysis. There will be low hemoglobin. Consumption of platelet leads to decreased platelet count, and intravascular hemolysis leads to cystocyte and increase amount of increase LDH and increase reticulocyte count. And also all the parameters of bleeding is increased. BT, CT, APTT, PT all are increased D dimer and fibrinogen degradation product, as there is huge and also low fibrinogen. So what is the treatment? Treatment is as usual. We have already discussed the treatment of multi-organ failure. You will must support the treatment for organ failure, acidosis, dehydration, renal failure, and hypoxia. If patient is bleeding so much, you will have to give fresh frozen plasma, cryoprecipitate, and platelet. But you never give tranexamic acid. It is contraindicated because it may lead to excessive clot formation and stroke and stroke-like manifestation, and you will have to give prophylactic low molecular weight heparin, or if there is very excessive thrombus formation and patient condition is very grave, you must give low molecular weight heparin. Thank you very much.